Okay, so good evening, everybody. My name is Jonathan Haluka. I just wanted to thank you for being here. I'm a third year at Toro, New York. I'm the co-coordinator of the SIR-CLI Fighters Journal Club with Omer Ali. He's a third year at UIC. We are both very excited to resume the SIR-CLI Fighters Journal Club, and we have 3 informative presentations on brand new topics to this journal club this evening. I would like to say thank you to Dr. Taylor for being here and providing her expertise and experience on these 3 topics.
Thank you, Jonathan. Let me just share my screen really quick and just get the presentation or mini presentation uploaded. All right. So my name is Omer. Like Jonathan said, I'm an MC at UIC. Really excited to be a part of this webinar this evening. We're really lucky to have Dr. Taylor, and I'm honored to have the introduction tonight for her. Dr. Taylor is a practicing vascular and interventional radiologist and currently serves as the assistant professor of radiology and medical imaging at the University of Virginia Health System. She is passionate about women's health and interventional oncology, and also routinely provides care and performs procedures for patients with peripheral vascular disease. Dr. Taylor also enjoys teaching residents and medical students and is an active mentor for many trainees. She is also an active member of the Society of Interventional Radiology and is the committee chair for the SIR Foundation Gala. So we're really excited to have her today, and we'd also like to introduce our medical student speakers for today.
So like Omer said, we have 3 student speakers this evening that all worked very hard and are very well researched on their presentation topics. They all have created very engaging presentations to make this more enjoyable and seem like less of a classroom lecture. So without further ado, our first student is Meet Patel. He is a third year at UIC. His presentation will be on type B aortic dissections and will also be presenting the INSTEAD XL trial. So Meet, take it away.
Hey guys, I would like to share my screen if that's okay.
Yeah, go for it.
So yeah, as mentioned, I'm a third year medical student at UIC. Can you guys see my slides okay?
Yes, we can.
Okay, perfect. All right. I'll stop presenting my video camera, so there's no bandwidth problem here. Just 1 second. So as mentioned before, I will be presenting on type B aortic dissection. So let's get started. So the brief overview, I'll be going into pathophysiology of aortic dissection, its diagnosis, clinical management, so medical and surgical. And then we'll take a dive into INSTEAD XL trial. So aortic dissection is classified in 2 big classifications, so DeBakey and Stanford. The more used in today's age is Stanford classification. Type A and type B. So type A is anything that involves ascending aorta. So on the left side, as you can see, ascending aorta or aortic arches. It's more of an emergent problem in the clinical scenario. And type B is something that involves a tear that is distal to the left subclavian artery. Some statistics about this dissection. So type A is more common, while type B a little less common, around 0.5 to 3.5 cases out of 100,000 cases per year or patients per year. Let's talk about pathophysiology. So as we may know, aortic wall has 3 layers: tunica intima, tunica media, and tunica adventitia. The problem occurs when there's intimal tear in the aorta due to shearing hypertension forces. And due to these forces, the blood leaks into what we call a false lumen. It separates the tunica intima from tunica media and creates this false lumen. And this can cause obstructions of branch vessels, which is one of the big problems. We name it as malperfusion. Another way of this happening is alternative arteriosclerosis or vasa-vasorum, which supplies the blood supply to the tunica media. This will cause degradation of tunica media, and again, it will make a false lumen separating tunica media from tunica intima. Here I describe some risk factors. The biggest one is hypertension in the acquired patients. 70% of type B have prevalent hypertension, while type A is a little less prevalent at 36%. Some of the other notable ones are like tertiary syphilis. This is the vasovasorum pathway that I talked about, and inflammatory like Takayasu arthritis. And then genetic, these patients will show up much younger, maybe teenager or even younger, and these are Marfan's and Ehlers-Danlos. I listed some differential diagnosis of aortic dissection. The commonality between this and aortic dissection is that they refer shoulder pain and back pain due to irritation of the phrenic nerve. So myocardial MI and pericarditis and such. Most patients who do come in, so they will have this clinical presentation of a clinical triad. Most common is the severe tearing pain. In the posterior chest, if it's a type B dissection, posterior chest that radiates to the upper back, and associated abdominal pain in some cases, and that abdominal pain is due to the malperfusion syndrome, celiac artery, SMA, and IMA, or renal arteries. And then third part of the clinical triad is the pulse deficit. And then the third one is, sorry, that was the second. The third one is widening of mediastinum. As you can see on the right, the picture to the right side, there's a increase in the diameter of the mediastinum. So the lighter densities, you can see that's the wider mediastinum the arrow shows. And there's, you can see the aortic knob as well on the top left of the patient. This table to the right shows aortic dissection detection score. So every column has different conditions. And if it is positive, you get 1 point for any of the rows in the 3 columns. If your ADDS is more than 1, you're worried about aortic dissection and you should get CTA to compare to say pulmonary embolism or something. If your score is less than 1, you would like to do the D-dimer testing, as the flow chart on the left side shows. And if the D-dimer is high, then again, we want to do a CTA. Going on to the relevant imaging. As I mentioned, chest X-ray avoidance of more than 8 centimeters. You're concerned about aortic dissection. CT is your mainstay of diagnosing a dissection. It is very sensitive and highly specific as well. On the right side, you can see mostly in tile C, the white arrow shows the intimal tear on the very top, and then the black arrow show the intimal flap separating the false lumen from the true lumen. One caveat about CT imaging is that it does have a chance of motion artifact due to cardiac motion, and it could sometimes be seen as an intimal flap. And it takes longer than TEE, which is a transesophageal echocardiography, which can be employed in like an acute dissection, like a type A dissection, when you don't have time to get a CT. So the biggest pro of TEE is that you can use it in acute settings. On the right side, the tile A shows the infolding of the intimal flap. That is a level of ascending aorta. And on the B, an intimal flap on the level of descending aorta. C through E shows you the true lumen versus the false lumen, and you can also see the intimal flap there. Going on to MRI, the biggest con of MRI is long waiting time. And the biggest pro is that you get functional data. You get to see blood flow, and gives you more structural information as well for surgeries. Going on to clinical management, the primary goal in patients who have complicated or uncomplicated type B dissection is that you want to control their blood pressure, as that is the biggest reason of the initial tear. So the goal is to control the blood pressure and have it below 120/80 and heart rate below 60 beats per minute. The first line for these goals are a beta blocker. You can also use nitroprusside for a refractory hypertension, but be careful with the nitroprusside. You don't want to give it without a beta blocker, as it will cause a refractory tachycardia. And then CTA guidelines for patients who are medically managed only is 1, 6, and 12 months of CTA, like doing it every 1, 6, and 12 months, just to detect any extension of the dissection, malperfusion, or aneurysms. And once the blood pressure goal is met in acute hospital setting, you can transition them to oral medication and just get the CT as I mentioned. The surgical management, what we do is either open surgery, which is something of a past now, or TWAR, which is a new innovative surgery. We do these days. It stands for thoracic and endovascular aortic repair. So you would want to start a femoral access with endografts, and you want to size it to the non-dissected part of the aorta, so like 2 centimeters above the initial tear, as you can see on the right image on the top. The tear in the inner wall, and the stent starts like about 2 centimeters above. And the picture underneath that shows you like an extensive graft in case there's an extensive dissection, which goes all the way to like the bifurcation of the aorta. It uses a regular stent graft and then covers something called a petticoat, which is a fenestrated stent, which allows the blood to flow into the branches and not obstruct the blood flow. Here I want to talk about mostly uncomplicated. I'll get into complicated later, but just so you get what complicated versus uncomplicated mean. So uncomplicated is any dissection where the pain is easily managed with medication, and hypertension is also managed with medication. And we'll get into complicated. So the complications of the type B dissection. The biggest one is malperfusion. The scariest one is complete rupture of the aorta, because the mortality, even though prevalence is low, like 10%, it is scary because mortality is very high. On the right side, I show what you can do to treat against malperfusion. You can put a balloon catheter, balloon dilation, and put a stent graft into a true lumen tube. It's pretty much making a re-entry tear distal to the entry tear, so you can revascularize the branch vessels. Further talking about the TUR, who it should be given for. So outside of the complicated cases, anytime you have complications like malperfusion, you should be thinking about TUR and you should intervene. Outside of that, you should keep an eye out for patients who are impeding towards the complications. So aneurysmal degeneration, 20 to 55% prevalent, and rupture, which is the scary one, and malperfusion and uncontrolled hypertension. There are some objective measures, for example, progressive aortic dilation, like 5.5 centimeter of aortic dilation. You would want to intervene with the TUR. Aortic expansion, like 5 millimeters per year at the expansion rate, or the other things like malperfusion, refractory hypertension. The goal is pretty simple: seal the primary entry tear and divert the flow back into the true lumen, and that will help you open up the true lumen back up. This will also cause remodeling of the false lumen or the aorta. So it will cause the false lumen to thrombose and then regress over time. Here I wanted to talk about the settings of type B dissection. So we classify it in acute and chronic. Most of the time you want to intervene in subacute time. So subacute is like 2 weeks to I think 15 days to 90 days. And this is a prime time to intervene, because if you do any earlier, then the internal flap is very fragile and it will cause even higher chance of retrograde type A dissection. If you do it in a chronic period after 90 days, there's a chance that the false lumen has completely thrombosed, and putting a stent in will not expand the true lumen. And then some objective measures here. So the biggest one, most important one on the slide is the true lumen volume to the false lumen volume ratio. If it is less than 0.8, it's a high predictor of needing an aortic intervention. If it is above 1.6, then you have some freedom in choosing just the medical management versus TUR or medical management. And you should not use TUR, should not employ TUR and connective tissue disorders like Marfan's. Usually go with open heart surgery for those. And then this slide these are some of the radiographic risk factors. So these patients, if you have these risk factors, you will want to think about getting TOR done earlier than later, as you will have increased prevalence of some kind of complication. So the big ones are like false lumen that's bigger than 22 millimeters, and the entry tear is more than 1 centimeter. Contraindication, absolute contraindication to TOR are they root in anatomic abnormalities. So if they are respiratory, if it's infected, you can't gain a vascular access, you can't do a TOR. Then you would have to go into open surgery. Some of the complications that I already mentioned before, what can also happen post-TOR are like stroke. You can malperfuse an organ if the stent is on the branch vessel. Spinal cord ischemia, that's pretty common. And retrograde dissection, converting a type B to a type A, becoming an emergency, and you would have to do an open heart surgery. On the tiles on the right, A to D shows like post type B dissection TOR procedure. There's an endo leak that's being shown, and the important one is tile F to G. The red arrow shows a re-entry tear from the false lumen, and there's, if you look proximal to the stent, there is a type A dissection that is occurring. And then let's get into the INSET trial. So this is one of its kind, multi-center, I think it was done in Europe, randomized controlled trial that aimed to assess the benefits between TOR plus medical management versus only the medical management, specifically for uncomplicated subacute type aortic dissection patients. It was initially for 2 years, but then the authors decided to extend it to 5 years to get more long-term results. And we'll discuss the results. These were the inclusion and exclusion criteria. As I mentioned above, it's pretty much infection and stuff that would put the patient at risk. So complete thrombosis of false lumen and such were the exclusion criteria. The inclusion criteria, the biggest part was the subacute aortic dissection range I was talking about, the 2 to 52 weeks. The patient recruitment for that, it was a 1-to-1 randomization to TOR plus optimal medical therapy, and the other group was only optimal medical therapy. As mentioned, the 2 to 52 week window for the subacute phase of the dissection. And the analysis was done with intention to treat. Intention to treat means we follow, or the authors followed everyone's data regardless of them dropping out of the study or crossing over to the different group or dying to causes like accidents or other causes. This slide just shows the post 5-year follow-up patient characteristic. There was no significant difference here. Now for the trial intervention, the optimal medical therapy included was at least a beta blocker, and if the patient needed more, like a calcium channel blocker or nitroprusside, it was based on physician's distribution. And for TOR, the stent graft used was the old style Medtronic talent graft. This is one of the case reports from the study. Just shows the remodeling of the aorta going from the left to the right. 3 months and 12 months later, you can see how the true lumen has opened up and false lumen has pretty much regressed. The outcomes that INSET trial aimed to look at were primary outcome was all-cause mortality, which just means any cause of death, not just aortic. The secondary outcomes were aorta-specific mortality, progression of the aortic diseases, and then aortic remodeling and dimension. So I'll discuss these findings. The analysis they chose to do was a landmark analysis. As you can see on the right side, figure A on the bottom graph. This is just a regular findings resulted from 72 months. And on the top, what they have done is at 24 months, they reset the baseline and then compare the two groups from like starting point of 0. This was the primary outcome in graph A. The secondary outcome, the aorta-specific mortality, same thing with the landmark analysis. I'll discuss what they found in a second. And then graph C discusses the progression of the disease. So what did they find in the results? So in the INSET trial, while there were no statistical significant differences at the 2-year follow-up between the endovascular and medical group, favorable aortic remodeling was seen in 91% of the endovascular group, compared to only 19.4% of medically treated patients. And then after the 2 years, with a longer term follow-up of 5 years, all-cause mortality was again not significant for endovascular versus medical treatment, but aorta-specific mortality and progression were significantly lower for endovascular compared to optimal medical treatment. The mortality decreased to like 6.9 for the TVAR group versus 19.3% for the only medical management group. And then this slide shows the statistically significant aortic remodeling for all the patients after 5 years for the TVAR group. Complications, there were 3 conversions from a TVAR to open heart surgery during the trial and 2 spinal injuries. Authors did mention that procedural risk could be lowered with updated TVAR and patient being referred to a high volume care under more experienced physicians. The limitations were that patients only in the subacute window of type B dissections were taken, and only elderly patients were not selected for the study. Future considerations for the INSET-XL trial is that while TVAR is combined with OMT in this study, it can further decrease mortality and complications with surveillance imaging. TVAR should also be explored with asymptomatic patients at risk, and this is like ongoing study. So what kind of complications are we talking about? Like critical false lumen diameter, partial false lumen thrombosis, and larger entry tear, which was not selected for INDEX trial or INSTEAD trial. And more prospective randomized controlled trials should be performed to investigate long-term benefits of TVAR. And these are the citations. And thank you for listening to the talk. If you have any questions, I'd love to take them into the chat and we'll answer them there.
Great job, Meet. Thank you so much for your presentation. There's a lot of good stuff that I'm sure a lot of medical students will come across in the clinical rotations and training years. Dr. Taylor, do you have any remarks or comments you'd like to share about management of aortic dissection?
So first of all, great overview of just type B dissections in general, as well as the article. I think this whole concept of aortic remodeling, particularly positive remodeling after TVAR, sort of really changed the game as far as who we put these in, because it did at first. It was like we put them into patients who are at risk, who fell into that complicated category and had malperfusion and things like that. And that was sort of all it was relegated to, and everyone else was just medical management. And I think this study, as well as the other studies that are sort of similar, kind of changed that and made us think, well, maybe everyone should actually be treated in order to prevent some of these longer term complications down the line. So I think that's super important. And at UVA, we tend to sort of err on the treat more people than less people side. And so we do kind of follow this kind of algorithm where if they're uncomplicated at the beginning, meaning there's no malperfusion or anything like that, then we'll treat them medical management in the acute phase and then let them get into the subacute phase and then bring them back for an elective TVAR at that point in time. I don't know what Dr. Vatican-Jerry has to offer from that, but that tends to be our algorithm.
Thank you, Dr. Taylor. Does anyone from the audience have any questions? Feel free to use your chat or your voice mic if you'd like to. Otherwise, we'll probably move on to the next presenter. So next up, we have Kevin Gernavage. He's a MS1 at Touro College of Medicine in New York. He's going to be presenting on the medical management of peripheral arterial disease, or PAD, and critical limb ischemia, or CLI. And he'll also be presenting the Fourier trial for us today. So without further ado, Kevin, are you ready to share your screen?
Absolutely. Thank you, Omer. So let me just bring it up. Okay, so can everyone see my slide? Okay, yep. Perfect. All right, so yeah, just like how Omer said, I'll be presenting on the medical management of chronic limb ischemia. So we'll just jump right in. So just an overview, we're going to go over an overview of PAD, the different treatment modalities in regards to medical management, and just we're going to discuss a bit about the Fourier trial and about the PCSK9 inhibitor and its implications for treatment of PAD. So just an intro of PAD. Basically, it's a narrowing of the arteries, results from reduced blood flow. It's often due to atherosclerosis. So the most common sign with PAD is actually claudication, which is basically pain upon doing exercise or upon ambulation. Ulceration and then the resting pain usually come with more severe forms of PAD, such with a chronic limb ischemia. So there's obviously a disease burden when it comes to PAD. It affects many people throughout the world and in the United States. And in fact, with many people over 65 years of age in the United States, it affects about 12% of that population. And then just this number, this ABI, you'll be seeing this a lot. Basically, it's a main marker of whether folks have PAD. I'll explain a little bit more later on, but just remember this: if it's less than 0.9, it's indicative of PAD. So we have the Rutherford classification here. Basically, it's a way to categorize PAD, and specifically whether it's acute or chronic limb ischemia. Basically, it correlates whatever clinical signs and symptoms we see with the objective criteria, which is usually related to how far someone can walk on a treadmill, and then just the differences in blood pressure between different parts of the body. So claudication, like I mentioned before, it's just pain caused by decreased blood flow to the extremities upon walking. Usually with early on with PAD, folks don't really feel it at rest. They'll rest for a bit and the pain will go. Once that pain stays, even while they're resting, then that's a worrisome sign for CLI, for chronic limb ischemia. And this just shows the different areas where pain can result, and it can clue a clinician into where the occlusion is. In terms of critical or chronic limb ischemia, basically that's categorized by a greater than 2-week length and having that ischemic rest pain that I mentioned before, as well as non-healing wounds and ulcers, and then eventually later on, as the disease progresses, it gets to gangrene. So with this ABI number, usually anything less than 0.9 will be indicative of PAD. Anything less than 0.5 will be indicative of critical limb ischemia. And then here are the risk factors. Like I alluded to before, anyone over the age of 65 is at risk for developing PAD, as well as anyone that may have any of these comorbidities like diabetes, hyperlipidemia, hypertension, and renal dysfunction tends to be the most prominent one. In terms of diagnostic testing, I'll finally explain the ABI. So that's the ankle brachial index. So that's basically the ratio between the systolic blood pressure measured in the ankle compared to that in the brachial artery in the arm. Basically, a normal range for that will be between 1 and 1.3. So really anything less than that, less than 0.9, will be indicative of PAD. Toe brachial index is pretty much the same thing, except you're comparing the toe systolic pressure to that in the brachial artery. Skin perfusion pressure, that's just testing to see what the blood pressure is that's required for restoration of blood flow in the capillaries. And then ultrasound and peripheral angiography, that's just your anatomical assessment to find out, we're using medical imaging, where exactly the occlusion is. And these are just the values that are used to diagnose either PAD in its early stages or CLI when it progresses. And then this chart just pretty much breaks down which diagnostic measures are recommended. A lot for CLI specifically, a lot of it is based upon what the ABI is for that specific patient. And then after that, whether there's evidence of wounds or gangrene. And that will dictate whether we use a TBI, ABI, or one of the perfusion assessments, which are in yellow. So just manifestations of PAD and even more specifically CLI. So on the right, you'll see evidence of classic signs of CLI. You'll see the skin discoloration. You'll see the beginnings of the non-healing wounds, which could progress to gangrene and just more serious manifestations in the future. On the left, you'll see when the patient raises their legs, they'll have elevation pallor. So you'll see a little paleness on the right sole of that foot compared to the rest of the foot, as well as a dependent ruber once they put their feet back down. That's actually known as a Berger's test, which could also indicate PAD. Obviously, the main complication that you'll see if PAD and eventually CLI is untreated is obviously amputation. It's something that any clinician would like to avoid, especially considering that many folks who have to undergo below the knee amputations will need another above the knee amputation in the future, as well as the fact that the mortality rate for folks with CLI, the 5-year mortality rate is near 50%. So anything to improve medical management is key. We have the different modalities of treatment right here. I'm going to go through each one by one. We'll start off with our anti-platelet and anticoagulation therapy. So obviously what's used for asymptomatic patients with PAD, as shown by the chart here, is aspirin. So aspirin, as well as clopidogrel, which you may know as Plavix, they're both antiplatelet medications that use different mechanisms, which is why for symptomatic cases, for certain patients, they use both aspirin. For people, specifically for folks with a coronary stent or some coronary syndrome, they'll use a dual therapy, just because they use the different mechanisms. For standalone, for patients with symptomatic PAD, or with CLI rather, it's been shown that Plavix works a little better than aspirin. When it comes to anticoagulants, the main one I'll talk about here is rivaroxaban. This is used in cases where revascularization is necessary. So the difference between whether rivaroxaban or Plavix is used, there haven't really been any studies that show whether one is better than the other. There seemed to be a reduction in adverse cardiac and limb events with rivaroxaban in combination with aspirin. The key here is if the patient is they have to be screened to see if they're at risk for major bleeding events, which could happen with rivaroxaban, which you may know as Xarelto. In terms of cholesterol control, so you may have the instinct already that it may be a good idea to lower LDL for folks that suffer from PAD, and you'd be right. So a lot of the studies have looked at how atorvastatin specifically helps patients with PAD. So there we've seen an 18% reduction in adverse limb events in folks that are on moderate to high intensity statin therapy. And it also helps with the pain-free walking distance, which is a way we can measure the severity of a patient's disease progressions if they have PAD or CLI. In terms of hypertensive therapy, anti-hypertensive therapy, obviously PAD patients are susceptible to having MI, stroke, and a lot of the cardiovascular, major adverse cardiovascular events that we're going to talk about. So putting them on some sort of blood pressure medication will usually help their symptoms and reduce the risk of some adverse cardiac event from happening. With peripheral vasodilation therapy, cilostazol is a vasodilator, and it also has some antiplatelet component to it. So that's used just to increase the patency of the blood vessels. Patency just means the tendency of a blood vessel to not be occluded for there not to be a blockage. And obviously with that, we see improved claudication symptoms. There's lower risk of amputation. And of course, a major one is the decreased adverse limb events. In terms of exercise therapy, whether it's supervised in a hospital under the direction of a provider, or if it's done at home with the recommendation of a provider or a PT, let's say, it tends to be the same. It involves a patient walking on a treadmill to the point, up until the point till they experience some sort of claudication or some pain. And then they'll rest for a bit, and then they'll do another repetition of that. And then that training is usually done 30 to 45 minutes per session, and then it's done a number of times a week for at least 3 months. And then obviously with smoking cessation, quitting smoking is one of the best things you could do for an array of health conditions, and PAD is no different. It's been noted that there's been a decrease of critical limb ischemia, amputation, stroke, and MI. And that's usually done either through counseling, which may be some sort of behavioral therapy, or the use of a pharmacotherapy, whether it's a nicotine replacement therapy, the patch, combination of both. And this slide kind of just encapsulates the fact that despite the fact that all these strategies are very effective and the mortality rate for untreated PAD and CLI is so high, they're still very underutilized. So medical management of PAD is nothing to scoff at. It could be very important in improving health outcomes. In terms of how CLI is managed differently from PAD, obviously for both, it'll involve a lot of the same things that we just talked about in terms of smoking cessation, exercise therapy, and all the medication therapy. For those that are diagnosed with CLI, they'll also need some sort of pain management medication, because now at that point they're experiencing resting pain, sometimes even while they're sleeping, because that does involve raising of the limb. Antibiotic medications control infection that may result from the non-healing wounds and ulcers, surgical debridement for the wounds, as well as limb rehabilitation. And at that point, the patients with CLI may require more aggressive antithrombotic therapy, like the anti-platelets, the anticoagulation medication that we talked about before. And obviously at this point, tissue revascularization is the most favored treatment, because at the end of the day, we would like to avoid any major limb event like loss of a limb or gangrene. So now we'll move to the Fourier trial and the implications for PAD. So this trial was specifically actually meant for anyone with any kind of atherosclerotic cardiovascular disease. So it wasn't meant just for folks with PAD. It meant to test the clinical efficacy of a PCSK9 inhibitor, Avelumab. It just so happened that with the PAD subpopulation, with that cohort, there seemed to be very significant results. They made about 13% of the patient enrollees in the study. So basically with everyone, with all the 27,000 patients that were enrolled in nearly 50 countries, it just involved assigning them to either receive the PCSK9 inhibitor or a placebo via subcutaneous injection in combination with whatever statin therapy they were receiving. The endpoints here, the primary and the secondary endpoints tend to be very similar, just seeing to see how much of a reduction there was in cardiovascular death, MI, stroke, as well as any urgent revascularizations. And we just have some more exclusion criteria here. They had to be between 40 and 85 years of age. And obviously I mentioned before, they had to have some sort of cardiovascular disease, PAD being one of those eligible diseases, having an LDL-C level more than 70 milligrams per deciliter while receiving statin therapy. And then for anyone that had PAD, if they had any of these, they fell under any of these categories as well, that made them eligible for the study. All right, sorry. Going ahead. All right, so just talking about LDL receptors and PCSK9 and how PCSK9 inhibitor works. So just a review from biochemistry. So your LDL receptors tend to be most abundant on your hepatocytes. That's how we're able to bring LDL particles in through endocytosis. And then those LDL receptors could be recycled to the surface to receive more LDL particle, usually until their 100th cycle where they're degraded. Now with PCSK9, it's an enzyme that pretty much regulates the amount of LDL receptors at the cell surface level. That will usually bind to the LDL receptor as well, but then it will send it to lysosome for degradation right away. So you'll have less LDL receptors at your surface, meaning less LDL particles will be able to bind, meaning more LDL stays in the blood circulation. So you'll have a higher blood cholesterol level. Here, it just emphasizes that the subgroup of PAD patients seem to have the most significant, I guess, results in terms of the trial. They had the biggest relative rate of reduction, as well as the absolute rate of reduction, and then the number needed to treat was the lowest. So you'll see a theme with a lot of these charts in terms of the endpoints. So pretty much in terms of the primary endpoint, which is a composite of cardiovascular death, MI, stroke, hospital admission for angina and revascularization, there was a 21% relative decrease in that composite endpoint for people that took the PCSK9 inhibitor as opposed to the placebo group, which is very significant. And it's both the relative rate and the absolute reduction rate were greater for that PAD cohort as opposed to the folks that did not have PAD. And you'll see that pretty much the same theme here for just looking at cardiovascular death, MI, and stroke. The relative reduction rate was about 27%. For major limb events, it went down for folks that took the evolocumab by 42%, which is really significant. And then just in terms of a combination of either major adverse cardiac events or major adverse limb events, just for both of those, there was also a pretty significant decrease in the RRR by 21%. So in terms of study limitations, the results seem really promising. What a lot of the review literature has pointed to is the fact that the study lasted about 2.2 years. So there may be long-term follow-up needed to kind of look for all of the other things listed below here to see if there's any safety concerns that may be needed to be monitored over a longer period of time. Also, the fact that there was no reduction in cardiovascular death in terms of mortality at 2.5 years, that it's been suggested that could be because it was such a short amount of time, that wasn't enough time to kind of register a decrease in mortality. Obviously, that now this may be more related to just future considerations, but there is a prohibitive cost of evolocumab. So obviously, it's great that it works for a subpopulation of PAD patients, but that is a concern that needs to be taken into account in terms of cost-benefit analysis. And while there were reductions in many of these adverse cardiac and limb events, the results still show that dyslipidemia, while it's one of the major factors that contribute to chronic limb ischemia, it's not the only one. Nevertheless, the trial does show that by lowering a patient's LDL level significantly, it does reduce the number of those cardiac events. So it does inspire clinicians to revise guidelines in terms of the LDL-C levels. And then compared to statins and other therapies, PCSK9 seems to have minimal safety concerns compared to those therapies. The long-term effects will still have to be investigated. And then the investigators will still have to see if there are benefits extended to patients with lower risk profiles. And the good thing is, and we're going to finish off here. So there's few therapies that exist that are proven to reduce both the incidence of MACE and MALE of those adverse cardiac and limb events. So the fact that PCSK9 inhibitors work so well in doing this is certainly something to be excited about. And the fact that it was able to lower LDL-C levels to such a level to pretty much almost 20 milligrams per deciliter, that kind of has spurred some clinicians to reconsider if targets should be lowered with the purpose of preventing all these adverse effects that patients with PAD might suffer. And last thing, the fact that clinicians want to investigate if they can figure out a way to use PCSK9 inhibitors earlier, because you can think of cholesterol, the years that you have high cholesterol as years that you've been smoking, kind of like pack years. So the more time you have high cholesterol, the more damaging effects it can have on the body. So if we can introduce this therapy to patients earlier, maybe before they develop a CLI or more severe forms of PAD, it'll reduce those adverse effects, which will only improve health outcomes. And I think that takes care of it for me. Thank you so much.
Thank you, Kevin, on that great presentation on a somewhat broad topic, but definitely clinically relevant and transcends across many specialties, not just IR. Dr. Taylor, is there anything you would like to add on medical management with your patient with PAD?
So obviously there's a lot of medications out there, and all these different trials sort of look at kind of one at a time, you know, and so there's still so many questions left to be answered. I think this trial is very interesting for a lot of different reasons. One of which is just how low they got the LDL score. You know, I think some of them are less than 10, and that's just amazing to me. So I think that, you know, will be something that people can focus on in the future, is other ways that they can do that. You know, I have no personal experience with these medications, but I also found it interesting that there's really no adverse effects that they mentioned. They said that it was, you know, very minimal or nothing significant, and they didn't really elaborate on that. So I would be interested to know, you know, how true that is, because that sounds like a magical drug, right? Like something you can give to everyone that does all of these amazing things and has no effects. So, you know, maybe that's why it's so expensive. But so I think that'll be interesting to kind of suss that out.
Yeah, definitely. I agree. That's probably a limitation to this study. Anybody have any questions in the audience? Feel free to just use your microphone or just put it in the chat, whatever you like. All right. So our last speaker of the evening, last but not least, is going to be Sebastian Veska. He is a second year at Toro, New York. He is going to be presenting calcified PAD as well as intravascular lithotripsy, which is a very novel and cool therapy that many of us have an interest in learning more about. And his trial he will be presenting is the Disrupt PAD 3 trial.
Yes, hello, thank you for having me. I'm just gonna share my screen. If I am allowed to, can you guys see it? All right, fantastic. So we're gonna start the slideshow. So like Jonathan said, I'm going to be introducing intravascular lithotripsy. And the first thing that I want to do is introduce you guys to what calcified arterial disease is, understand the pathophysiology behind it, and understand who are the populations that are at risk for it, how we can treat calcified PAD, what intravascular lithotripsy is, why do we need the procedure, what are the possible side effects, and most importantly, the Disrupt PAD 3 trial, which we'll go into more detail later on. So, like I said, calcified PAD, Kevin explained what PAD is, but there's also a form of this where we have two categories. We have intimal calcification and medial calcification. Basically, this is just vascular calcification, which many ways to say it is just ossification of the arteries. As we know that there's the intimal layer of your artery, which usually this is affected by arteriosclerosis, and then you have the medial layer, which this has to do with more diabetic patients and chronic kidney disease patients, and then this is the medial layer. So intimal calcification, like I said, arteriosclerotic plaques, as we all know, have to do with hypercholesteremia, fat accumulates, then we have our macrophages act on the cholesterol, and then everything gets oxidized, and then it all builds up as a plaque. As the plaque starts building up, you start getting obstruction in the artery, and this could create serious problems, such as dissection, blockage, It could create blood obstruction, and that has to do with intimal calcification. But next, we talk about medial calcification, which this has to do with the medial layer of the artery. The medial layer of the artery, you're not obstructing the inside of the artery. You're kind of just inhibiting the medial layer, which has to do with the muscular part, and your artery loses its elasticity and compliance. Basically, you can't really pump any more blood, and the artery becomes very stiff. As the artery becomes stiff, it's almost like obstruction, like you can't really get blood through. So you're gonna have some of the same symptoms, it's just as caused by different mechanism. The mechanisms right now are still being studied. It's not very well known. What the theory is that due to diseases like type 2 diabetes, chronic kidney disease, you have accumulation of calcium and other mineral deposits. The deposits then become remodeled, such as bone. It's kind of like mineralized bone on the medial layer of the artery. And that just becomes very stiff, like a bone, and your artery doesn't work anymore. Like you can't really pump. And here's the diagram where it explains it better, where you have the hyperphosphatemia, the hypercalcemia, and then the medial layer. And then here's all the metabolites. You could get inflammatory, which would have more to do with arteriosclerotic plaques, which is the intimal layer. You have a bunch of medications that can cause side effects to it. You have hormonal disorders. And all of this could cause accumulation of minerals, which can then harden the artery or create blockage. So who are the populations at risk for this? Well, as I said before, medial calcification has more to do with accumulation of minerals. Diseases that have accumulation of minerals are people who have chronic kidney diseases. You can't clear out the minerals, you can't clear out your blood. These people will have accumulation of phosphate, calcium, and many different things. Type 2 diabetics have a significant problem with their arteries as they age. It becomes calcified in the medial layer, as a lot of calcium gets built up on that area, and your arteries just become stiff. Intimal calcification has to do with hypertension, hypercholesterolemia, and diabetes too. As we all know, hypercholesterolemia builds up cholesterol, the cholesterol builds up, the lipid accumulates, and then that's how you get obstruction of the artery. The people most affected by it are the elderly population, usually above 70, and also smokers. PAD has complications such as extremity ulcers, cardiac claudication, and rest pain, as Kevin talked about. And this is an ongoing problem in the US and around the world. I mean, more than 5 million individuals just in the US have it. As our population is getting older and we're living for longer age, this is just becoming a significant problem that really needs to be dealt with. So here, Kevin already explained how you diagnose PAD. So I just kind of want to add on, as he talked about the ABI, when your ABI is above 1.4, that's also not good. Usually it's either an error or it means that your artery is stiff and your ABI is like super high, because this is type 2 diabetics or any diabetics at older age. Your artery becomes stiff and your ABI becomes abnormally high. This could be a sign of PAD. Also, ABI less than 0.9 is also a sign of PAD, and usually that has to do with more intimal obstruction. And like Kevin said, it's usually around 0.9, 1 to 1.3 is normal. Unless you have claudication symptoms, then you test it out, but usually that's a normal reading. And Rutherford calcification, I just put it here because this is very important. Kevin already explained it, but again, it's a grading system. As it gets lower, you get gangrene, you get really bad, and this all needs treatment. This is some of the same images that Kevin showed. This is some of the manifestations of PAD. Complications, it could get really bad when you need amputations and gangrene. So here, I'm going to talk about how you treat PAD, especially in the early on. We have endovascular revascularization, which is basically you open up the artery somehow so they could get revascularized and the blood can get through. One of the most common uses was percutaneous transluminal angioplasty, or short for PTA. There's also other aggressive medical management like lifestyle reduction, drug therapy, like Kevin explained about like the different types of drugs that you can do, or open revascularization, which is pretty, it's the most intense one, where you literally just create a bypass graft and you redirect the flow of the blood on your lower extremity It's usually a last resort. It's not usually something you want to do, but it's one of the other treatments for the more severe. Here is the balloon angioplasty. Is basically you just insert a catheter with a balloon. The balloon opens up and it opens up the artery. And then you could also put bare metal stents, which open up the artery and allow the blood to flow. Kind of how you treat a lot of the obstruction of vessels. So here is just a more in-depth diagram where it shows the different types of balloons that you could do. You could do a drug-coated balloon, you could do a drug-eluting stent, you could do different types of stents, you could do bypass grafts, and there's many different treatments for it. Here is one of the more specific treatments that are newer, that is called the SIR-PTX, which is basically a drug-eluting stent, which is, it's kind of like you just place a stent, you open up the artery, and then it's coated with a drug called specifically paclitaxel, which basically prevents the artery from getting restenosis by inhibiting the mechanism of neovascularization on the artery, so that you prevent the restenosis of the artery, because that's a common complication after a lot of these procedures. So, like I just talked about, there's many complications with a lot of these endovascular procedures. One of the big deals is that the PTA, you put a bubble inside your artery, but that bubble requires a lot of pressure to open up the artery. When you create that much pressure, you could create breaks in the artery, you could create dissections, and even after the procedure is done, there could be restenosis of the artery. As you can see here in these images, you have different types of dissections when you use these type of procedures. These type of procedures can also create distal embolisms, as you're like opening up that artery, removing some of that clogged area, but then that could go somewhere else in the body and you can get pulmonary embolisms, you get different types of embolisms, you get strokes. And the problem with these type of procedures like PTA and the aorticectomy with the bypass, they never really treat the calcium in the medial layer. Like you never really break that medial layer. So the artery is still stiff. You're kind of just opening it up, but the artery can still be stiff. The compliance and elasticity can still be malfunctioning. You never really deal with that area. Here's just another picture of a 64-year-old diabetic woman who had severe calcification of her artery. They did they took out her artery, the endorectomy, and then they just kind of took it out, and this is how it looks. It's severely calcified. There's no compliant. Blood really couldn't flow through it. It just stayed there, and it created PAD symptoms. So one of the problems with calcified PAD is that we don't, as you saw with everything else, there's a standard scoring system for like Rutherford calcification and everything, but for calcified PAD, there is not a standard scoring system on how severe it is. There's several papers, they all have different scoring systems. This is just one of the most famous scoring systems from one of the papers that talks about the different grading, where there's unilateral calcification, where there's intimal calcification, they have a different grading system. If it's bilateral calcification, then it goes lower into grade 3 and grade 4, and the more severity. But as you can see here in this left image, here's a calcified artery. As you can see, there is no blood going through, and then it has a procedure with PTA, and then it opens up. So, as we talked about calcified PAD and the previous procedures that had a lot of complications, a new need for a new procedure came up. And someone thought of a genius idea, why don't we do lithotripsy? Lithotripsy is usually used for kidney stones, and you break up calcium kidney stones, and that's how you pass kidney stones. Well, what about if we use it for intravascular purposes? So basically, it's a similar method where you use multiple emitters and you mount it onto angioplastic balloon catheter. So you can insert it into the artery, and once it's inserted to the artery, you build up the balloon, and then the balloon does a lot of pulsatile pressure energy, which can then disrupt or break some of that calcium that's stuck in the intimal to medial layer. And if you break up that calcium, then your artery could become more compliant and it's not as stiff. While doing this, you don't need to add that much pressure. You only need to add 4 atmospheres to 6 atmospheres, which doesn't affect the local soft tissues around. It doesn't create emboli because the pressure is so low and the pulsatile energy that it doesn't break it off into your arteries. And this mainly serves as a novel vessel preparation strategy. What does that mean? That it mainly just breaks it up so that then you could put stents, or you could put other drug balloon procedures there to maintain the artery open. The main purpose of this is just to open up the artery so you can insert maybe a stent or something else, so the procedure will maintain there and the patient will continue to have an open artery. So here is just, again, here's the generator, here is the catheter with the connector cable. How it works is, again, you just create a bubble, the balloon builds up, and then from there you can do pulsatile sonic waves that then they're rapidly exploding, which breaks up the calcium in the artery. And this is just another cool image that shows it in a much better visual. Here are the steps. Again, like I said, it's only about 4 atmospheric pressures, because if you add more, then you could create dissections and you could create other problems. So the low pressure really maintains the artery without dissecting it or creating emboli or creating other significant problems. So here is a study that has to do with calcified coronary lesions and that uses IVL or intravascular lithotripsy. So they had 3 different groups. Group A had to do with coronary artery stenosis that was new, and B and C had people who already had severe coronary stenosis. They tried other procedures such as balloon, but it was non-compliant, and then they used IVL. They followed this entire groups, and in this diagram you see how the strategy success, which means that there's less than 20% stenosis after the procedure was done, or re-stenosis after the procedure was done. And you see that group A had the highest success rate because it was just new calcification. Here, the middle group, which had more to do with moderate to severe calcified coronary lesions and a non-compliant balloon. And then the last group, which had to do with, they had already placed a stent and then they tried ballooning and it was not compliant, and then they tried IVL and it had a 64% success rate. And here is just the diagram again. It's the same groups. A, it shows how there is there's calcifications and blood is not flowing through. B is showing when they place the IVL inside with the balloon and then they start the shock waves. Here is already immediately after the shock waves and some of the calcification. And here is when the final results after they put a drug-eluting stent implantation after the IVL. And here you can see complete flow of the arteries. So here is another image that I just thought it was very interesting, that here's the pre-shock wave. Again, you see the red arrow pointing. Here's some sort of obstruction, usually calcified. Here's an image of the obstruction where it shows the stars. Here's calcification of the medial layer. Here's a very obstructed artery that has a lumen of 2.5. Here is where they do some shockwave therapy where it already opens up some of the artery. You see that there's cracks in the calcification. There's opening, the lumen opened up to 6.15. And here is after the IVL and stenting. As you can see, the stents, the cracks, and the lumen opened up all the way to 0.32, 8.32. So now we're going to talk about the most important part of the presentation, which is the Disrupt Pad 3 trial. What is this? It's basically testing out IVL versus PTA, which is intravascular lithotripsy versus percutaneous angioplasty. This is the largest trial that has been done so far with IVL and PTA. It's a global trial. It's single blind randomized. It's controlled. It has to do global, Austria, Germany, New Zealand, and the United States, various centers. Again, it's the largest publicized randomized trial of endovascular intervention for patients with heavily calcified femoral popliteal arteries lesions. So the whole point of this test is, again, to show the outcomes between IVL and PTA, and then using either a drug-coated balloon or a stent afterwards to see if the artery maintains without being re-stenosed or any dissection complications. So the patients selected for this trial. So this trial had very specific factors to select their patients. They had a massive amount of exclusion criteria, and the patients selected, they took all their data, whether they had hypertension, hyperlipidemia, they took their RFS class, they made sure that it was between the RFS class of 2 to 4, they made sure that the stenosis of the femoral or popliteal artery was above 70%, they made sure that the lesion was a length of up to 180 millimeters or not bigger than that. They made sure that the reference vessel diameter was 4 to 7. They did angiographic confirmation studies to see if they can insert the IVL or the PTA. They made sure that it was completely randomized whether they selected one patient to go to one group or the other group. They even used a voice comm system where they didn't know which patient was getting placed in which, as long as they fit into this criteria. So what was the primary effectiveness endpoint, or what that means? Basically, what does it mean when the procedure is successful? Well, they said that the procedure is successful when they used the angiographic core laboratory, that the residual stenosis was below 30%, and that there was no flow limiting dissection following the randomized treatment. The secondary effectiveness endpoint had to do with after the 30-day post outcome of everything, they had to they determined using various factors such as ABI, roof for class, a health quality survey, whether the quality of life was improved or whether they had any walking impairment, whether they needed any new procedures to prevent restenosis or any other problems. That was the secondary endpoint. It had more to do with what happened post 30 days of the procedure. So here we have a diagram of what the trial is, which is basically just IVL, PTA. They put whether they needed post dilation required, which whether there was greater than 30% residual stenosis, whether they needed more post dilation, whether they fit the primary endpoint, whether a stent was required, drug balloon coating. And then here are the outcomes. Again, they split it evenly, 153 on one side, 153 for PTA, and they did imaging on both. They only had one withdrawn in each trial, and they made sure that after a 30-day follow-up, all the 152 and 152 were followed up. Here are some of the procedural details. So the main important part about these procedural details that I found interesting is procedural success. There was a significant p-value significance for procedural success of IVL. There was a higher success that reached the primary endpoint. There's much less dissections. There was no flow limiting dissections, much lower. The diameter stenosis was significantly better for IVL. And there was much less post dilation required and much less provisional stent placement for IVL. The post drug-coated balloon or stent after the IVL or either procedure was basically the same for either one. There was no significant difference. So here is just an image. A is when it's stenosed, the artery you can see is clearly blocked. Here's the B where they put the IVL with the drug-coated balloon. Here is just the IVL treatment as the artery opens up, and D is when they put the drug-eluting stent and the artery is fully open. Here's just the 30-day outcome trial where they talk about the quality of life, the roof for class. You see that there's really no significant p-value difference between the quality of life afterwards for either one. So here, what's a study without cold graphs? Here it shows the procedural success, that the success for IVL was significantly greater for either in the site reporter or on the core lab. Here it shows that IVL has much lower diameter stenosis than the PTA. And here the dissections were significantly greater for PTA than it was for IVL. So study limitations. IVL compared to PTA, they only compared it to PTA. They didn't compare it to other studies like drug-eluting stents, like arthrorectomy. They didn't compare it to other studies that had calcium modifying technologies, because the trials have very specific parameters that couldn't be compared to other trials. The interpretation of the 30-day clinical outcomes could be confounded because they also use stent placement and drug-coated balloons, which means that we don't know if the IVL was the one that was causing the effectiveness, or it was the PTA, or it was the drug-coated balloons. The exclusion criteria did not allow for people with chronic kidney disease or critical limb ischemia, or people who had amputations to be a part of the trial, which a lot of those people are the ones that actually suffer from these type of calcified PAD. So that was a limitation. And the investigators and the research staff were not fully blinded, only the patients. And the investigators were also paid to do the trial. So there was also very much expectation bias for the trial because the investigators were paid. The future direction, I mean, the trial only sought for short-term outcomes. We need to follow up 2 years afterwards. We need to see how the treatment, if there's restenosis after 2 years, after long-term results. We need to make sure that other calcified technologies are compared to this type of trials. So here are references, and thank you.
Thank you so much, Sebastian, for the very insightful presentation on a topic that's often not presented, at least at the medical student level. So really appreciate all the novel information you've shared with us. Dr. Taylor, do you have any comments or remarks you'd like to make about calcified PAD or the intravascular lithotripsy device?
Yes, so calcified PAD could be very challenging. Typically just conventional angioplasty is not going to be enough. Plus, it comes with the risks of dissection, and as were mentioned in this study. So I think the intravascular lithotripsy is sort of an exciting new way to be able to treat that, and especially with the the thought that it's not going to risk showering stuff. So your rotational atherectomy or orbital atherectomy devices, since they're sort of shaving down the calcium, is obviously at risk of showering things. So you have to use distal embolic protection, otherwise you're just going to shower little pieces of plaque all the way down to the tiny arteries in the toes, and then you're in a really bad place because you can't really lice that stuff out. So I think that's an exciting thing. It's fairly easy to use. It's not it's not hard. Just get a wire past it, put it in like you would a regular balloon, inflate it to sort of that very low pressure, that 4 millimeters, and then, or 4 atmospheres, and then turn the device on, and it just kind of does it for you. So it's I think that's an exciting new technology, and excited to see where it goes.
Thank you so much, Dr. Taylor. This is our last presentation. We want to open the floor for the next couple minutes. If anyone has any questions about this presentation or any of the previous ones, feel free to chime in. All right. Well, we'll definitely share the emails of the presenters today. We also want to give a big shout out to those who also supported this program. Dr. V, of course, thank you for attending and providing expert advice about all these topics with Dr. Taylor. It was really nice to see that commentary in the chat. We also want to thank Damien and Jonathan for their mentorship, since they've been a big part of this journal club. They were the co-founders, I believe, and the RFS MSc PR team that helped us advertise and share this with the IR community, especially the medical students. So we're really blessed to have so many great mentors and supporters. And of course, Dr. Taylor for taking the time to share her expertise and provide amazing commentary in the chat, and also after the presentations. Okay. All right. Well, thank you all for attending. We hope you learned something new today, and we hope to share this podcast with you, our video with you on YouTube sometime soon. Have a good evening.
Thank you, everybody.